Hello there. Today we are talking about functional neurologic disorders, or FND, and that it is not a wastebasket diagnosis, meaning it is not a diagnosis of exclusion, not a diagnosis that if you have weird things, you just throw it in that basket. That's what we're talking about today. We're going to talk about a lot of research. I have a lot of articles pulled up on my computer to share with you today because you've been sharing a lot of great questions and comments. So thank you for that. If we haven't met, my name is Julie Hirschberg. I am a neurologic physical therapist. I am the owner and founder of re+active PT. I get to wear my holiday re+active sweater you want this sweater still? I need to get you this sweater. Oh my gosh, hello from the Netherlands. Thanks so much for joining us for these chats, for these discussions. A lot of it based on your questions. And this one literally came from a person who said, hey, can you talk about the diagnosis? Can you talk about the positive signs? Because I think it's a wastebasket. I think I was diagnosed without positive signs. And I said, yes, let's talk about this. And I'm going to bring the literature and we're going to talk about it. So I shared this article. Let me find it here. I got it up in front of me and I'll share it in our newsletter every week. So if you're not in our newsletter, I send a newsletter every single week. On Fridays, I send it to clinicians. On Mondays, I send it to patients with things specific for you. And I send all the links and all the videos. And you can sign up at reactivept.com if you're a patient, or reactiveeducation.com if you're a clinician. But this article was published in 2022 in the British Medical Journal, and it's called Diagnosis and Management of Functional Neurologic Disorder, Selma Ibeck, David Perez. And I don't post the newsletter on the website, so but thank you for that question. Maybe I should in the future have a way that you can find old newsletters too, because I have had that before. So thank you for that question. I just have to figure out how to do that. What's the best way to do that? So this is a fabulous article. I recommend it really for everybody. And I will tell you, just as a little background for myself, I'm a professor at the University of Southern California. I teach other doctor of physical therapy students. The course that I teach is called neuropathology, and it's essentially a differential diagnosis course for physical therapists. And we go through actually all of the diseases of the nervous system. We have FND in that course this year. And we do cases where people present with signs and symptoms and we try to figure out what it is. It's really like we're solving a mystery. This is what I love. I love the diagnostic process in neurology. However, I am not a neurologist. The people who wrote this article are neurologists. I am not a neurologist. I'm a physical therapist. And as a physical therapist, every person that I see, every person that a physical therapist sees should be screened. So they might have a given diagnosis, but you're still doing an exam to make sure that diagnosis fits, or that the person might not have something else in addition. So I just want to give you that background so you know where I'm coming from when it comes to this. I don't give the diagnosis to folks, but when I see people, when I talk to people, I'm screening that actually matches. So I am sharing this article because it goes through the positive diagnostic signs. So there are a lot. So what I wanted to talk through first is, I'll stop sharing this for a moment, is what is the process? So people have asked, several questions. I was diagnosed without positive signs, they said. I was diagnosed only based on exclusion. So should I consider this a true diagnosis? What are the rule-in signs? Somebody asked very specific, what about functional visual loss signs? So such great questions. And I wanted to go step by step for what is that neurologist process and how do they get to the diagnosis of FND? And to let you know too that things have changed over time. FND was a diagnosis of exclusion. And then when they updated the DSM for the diagnostic manual, when they updated it, and I believe this was 2015, they switched it from a diagnosis of exclusion to a diagnosis of inclusion with positive signs. So it's not surprising. Well, maybe I am surprised that some people are still practicing in a practice before 2015, but hey, people take time to change, right? So some people are still practicing old school. Hold on. I'm just getting a notification that maybe my headphone isn't connecting. So if you can let me know if you can't hear me, that would be helpful. I might have to reconnect my sound. Just let me know if you're not hearing me. I hope you are. But as I was stating in the DSM, it was updated in 2015 with positive rule-in signs. Thank you for that you can hear me. Great. So what are those? What got updated? So there's criteria A and B. Criteria A for FND is, do you have one or more symptoms of altered motor or sensory function? Okay. Most people I know with FND have one of those pieces. Now, we also know there's subtypes that might be cognitive, right? So they might not quite fit entirely into motor and sensory symptoms. So altered changes in neurologic symptoms. The second is that the clinical findings provide evidence of incompatibility between the symptoms recognized in other neurologic or medical conditions. That is not a diagnosis of exclusion. I'm going to explain why, because there are positive clinical signs for different subtypes of FND that are very specific to FND. And so a little statistics 101, by the way, I always have to remind myself of what these terms mean. But when we look at clinical signs, we want to know, are they sensitive and are they specific, so that we can know if there's false positives or false negatives. Most of the clinical signs in FND are highly specific, and specificity when it comes to statistics is the percentage. It will show the percentage of people without the disease, so without FND, who will test negative. So for an example, a lot of the tests are like 90% specific. So a 90% specificity means that 90% of the people without FND will test negative on that test. That's what you want in a test, right? You want it to be very specific so that you're not getting false positives. On another note, by the way, in this article, they talk about how rare it is to be misdiagnosed, at least in the literature. I know people have been misdiagnosed, but in the literature, the misdiagnosis of FND is not very high, because these, when done correctly, these positive tests are positive and they're sensitive. So in this, I'm going to go through some of the subtypes and share with you a couple of their tables. So I grabbed a piece of one table here. So in the neurologic process, we're looking to meet these diagnostic criteria, and there are positive signs that a person would do in a neuro exam. Let me back up just 1 second, because before the neuro exam, a neurologist or physician or physical therapist would be reading the history, looking at other results, talking to the person about their timeline and history. And in all neurologic disorders, there are distinct timelines that can occur. Does something occur suddenly or slowly? Does it have relapses and remissions? Is it variable? These are all things that do occur in functional neurologic disorder. Typically, a sudden onset of a particular symptom that is gradually progressing Sometimes that could be a rapid progression for some people, but it has these flares. So for in FND, in a typical timeline of hearing a person's history, we would hear times where the symptoms were a lot worse, and there might be times where they completely go away. This is not very common in neurologic disorders, although we do know disorders such as MS and autoimmune disorders do have this type of timeline. But the clinician starts with understanding that history and timeline. That gives us some context. Then we're going to do a neurologic exam, sensory exam, motor exam. We're going to test reflexes. We're going to look at coordination. We're going to look at all the cranial nerves in the face and neck. We're going to look at cognition. We're going to bring all of those pieces together, and these clinical signs would be a part of that examination. So not only are we looking at, are there positive clinical signs for FND, like in this case, in this particular part of the table, it's motor, general signs in motor FND, but we're also looking at, are there other neurologic signs, especially because we know there's a high coexistence of FND with other neurologic disorders. So we want to know what those are. So let's talk about, we'll talk about a couple of subtypes and give you some general positive rule-in signs. These are motor signs. So you can see in this table, they have general things like distractibility, variability, and I included this in here because somebody asked me about visual pieces, convergent spasm and some eye movement abnormalities are part of FND. Convergent spasm in particular has a specificity of 87% for FND. So I just wanted to put that in there as a potential subtype. So these are positive motor signs. One of the things that the authors of this article caution against is just using one sign. So for example, a lot of people have heard of the Hoover sign. That's lower down in the table here. That's not the only sign. And there are folks with other neurologic diseases that might have a positive Hoover sign. You would, just like in any other neurologic disorder, you would look at a multitude of signs. And I believe when I went through this, they have table after table after table. We're talking like 80 potential positive signs, right? So there's a lot that a neurologist might do to test and give a positive diagnosis. These are some of the motor signs. Now, I wanted to give another common subtype that we see is functional seizures. And I particularly love this diagram. It's from an article on functional seizures and differential diagnosis. And this particular table shows some of the things that are unique to functional seizures. So this is the clinical feature on the left, common in FND and rare in epilepsy. So eyes closed. This is another very specific sign for a functional seizure. Duration longer than 2 minutes. Now, of course, if somebody has an emergency in status epilepticus, that can last longer than 2 minutes. But generally, the long duration is a very specific sign for a functional seizure. Very scary as well to have really long seizures, right? Hyperventilation during an episode, crying after an event. All of these are very common in FND and uncommon in epilepsy, and in studies have been shown to be signs that are specific to FND. Now, what is nice in the world of functional seizures and epilepsy is that we do have some gold standard tests. A video EEG is a gold standard test that can be done to help identify if a person has epilepsy or FND or maybe both. So that is a really great physiologic and clinical marker that can be done and tested for functional seizures and can give very positive findings. So we talked about functional motor disorders. Functional seizures was the second here. And then I wanted to share this particular picture. Oh, shoot. I don't have this picture to share with you. It looks like it did not download for me. Okay, so I'm going to talk through it then. And I'll share it in my stories. How about that? So this particular picture comes from an article from John Stone in 2020 that gives a visual of positive diagnostic signs. And it talks about the signs for functional weakness, like the Hoover sign, like the hip abductor sign. Then it talks about and it shows, and so I'll just demo these for you, for functional movement disorders. So there are distinct signs of functional dystonia, for example. So typically a functional dystonia will be in a fixed position. So if I see a person with task-specific dystonia or genetic dystonia, oftentimes I can see that movement occurring. But in a functional dystonia, not all of the time, but a distinct quality from other dystonias is that it's fixed. It's stuck in this position. Now, of course, that can happen over time in dystonia. But typically in functional dystonia, it's like that from the onset. Not in all cases, though. There is also typical functional dystonia facial presentations, and that is this episodic platysma. This is your platysma muscle, or the orbicularis oculi muscle contractions. Those are clinical signs of functional facial dystonia. And then tremor. Tremor is a really common functional neurologic disorder. And what we can see in functional tremor is a sign called entrainment. This is also has a high specificity for tremor. And what we would do in a entrainment test, if a person had tremor in their hand, so let's say I have a right arm tremor, I would ask the person to do a task at a different rhythm with their other hand. So this is a very common coordination task that we would do. And what we would look for is, does the hand train its rhythm to something else? So does the tremor change? This is involuntary, but the trainability of the tremor is a distinct test that is very specific for functional neurologic disorder. It does not occur in other types of tremor. It does not mean that a person is faking it, or they made it up, or they have some sort of voluntary control. Actually, it really shows us that there is a brain circuitry problem. And this is really what they have this really lovely picture in the article that I've been sharing about today, about why they would do these positive clinical signs, because they're looking for signs that this circuitry has gone awry. So the circuitry involving the sensory motor cortex and these and the networks with attention and self-agency. So that's what I think about when I think about an entrainment test or a Hoover test. We're pinpointing these network issues. I would almost say these are network tests. They are testing the networks, and they are showing, when they are positive, that the network function has gone awry. That's quite complicated. That is why there are like 80 tests listed in these tables. There's not one test that's going to tell you about all of these networks. So when we are testing attention and distractibility, we're really looking at the salience network as a component, right? And so that's why there's multiple tests that look at attention and distractibility. So I wanted to bring this picture because they included it in this particular review, but it's complicated, right? And it's no wonder that people have had poor experience in the diagnosis component of their journey, because this is the kind of stuff that neurologists or physicians are looking for. It's not easy. And I'm not trying to, take a bad physician off the hook. I'm not saying that at all. I'm just saying, hey, this is hard. This is really hard to do. There's 80 different tests. There is not an imaging test that can be done yet. Not yet. I will say, and one of the components that I wanted to share for functional movement disorders like functional myoclonus and functional tremor, they can be diagnosed clinically through the clinical exam. But if there are still questions, EMG and EEG can be done, and there are a couple of diagnostic signs that confirm functional tremor or functional myoclonus with those tests. So we do have some physiologic testing that can be done. Rolling and Strolling is asking, what about fMRI? So fMRI, or functional magnetic resonance imaging, I think this shows the most promise for us as a potential diagnostic piece in FND. But if we go back to this, there's a lot happening functionally in this brain, and multiple connectivity issues that might go awry. And so some of the things that we're seeing now in the literature are potential looking at biomarkers and looking at some of these patterns in fMRI that might help us understand particular subtypes of FND. Right? So it's very unlikely that we will find one fMRI finding that would be positive, because there's so much heterogeneity in a population of people with FND. But we might find some subtypes that way, right? So I want to get back. So we talked about what are the diagnostic criteria from the DSM. So we talked about that a person would have one or more altered neurologic symptoms, and then they would meet one or many, I would say not just one, but they would have multiple clinical signs that would match many of the things in tables such as this. Very specific signs for FND. These are positive rule-in signs. There are signs for motor FND. There are signs for dystonia. There are signs for movement disorders and tremor and myoclonus. There are signs for seizures that we touched on as well. There are signs for visual loss. In fact, there's a whole article on functional visual loss that I'll share in our resources this week that can be really helpful. So a doctor takes a history, a doctor does a neurologic exam and does a bunch of screens, and then would put this together to say, I think you have FND. Now, they would very likely say there might be a few things we also want to rule out. And so they may also order other tests, lab tests, EMG, MRIs to rule out other things. They may also find FND and some other things. And so this is where what we see a lot is that FND coexists with other disorders. So this is a slide actually from one of our weekend courses, and I'm currently putting together our differential diagnosis mini course for Brain Bites. It's in January. It's going to be so good. We're actually doing a case together. And I won't tell you what it is, but it's somebody that has more than one thing, which is quite tricky. So we know that FND can overlap with a lot. Just an article came out this year with 18% of people with tremor also have functional symptoms. 12% of people with epilepsy also have functional seizures. This is a wide range, with 7 to 66% of people with Parkinson's also have functional symptoms. 7 to 13% of people with MS. Autism is another area. 17% of kids with functional seizures have autism. 8% of adults with FND have autism. And this is really high, 87% of people with autism reported at least one FND symptom. These are things that we need to look for. When a person comes diagnosed with FND, we should be doing a full neurologic screen and testing to confirm it's FND, and also to look at the coexisting conditions, because we just see a lot of things that might be existing together. So I want to come back to some folks' questions, because what if you haven't had that positive diagnosis experience? What if you were diagnosed back before we had those diagnostic criteria in 2015, and so you were diagnosed on a basis of exclusion and you're questioning that, or just you saw a neurologist and maybe they did some of those tests but didn't explain it well. Maybe they kind of acted weird about it. I gotta tell you, people act weird around FND, and it's not your fault. For one, it's not your fault. A lot of it is the history of FND and the stigma around it. It causes clinicians to do really weird things, like not explain things. I've had patients where the doctor never told them they had FND, but then they brought up their report from the doctor and it said FND. It's like they didn't say it out loud. So they do weird things. And, you know, I do weird things as well. This is one that is very important to me, because those weird things become quite traumatizing. So to be given a diagnosis without an explanation is not part of medical practice. You wouldn't be given a diagnosis of having Parkinson's without explaining why or how you got to that diagnosis. By the way, Parkinson's is primarily clinically diagnosed based on positive signs and symptoms, just like FND. It should be treated the same when a person goes into a neurologist. They do testing and they explain what is the positive sign. So for some folks, potentially they had positive signs, but it was never explained. That's a very common experience that I hear. Or maybe they were only given FND based on a diagnosis of exclusion, and that person might look at the diagnostic criteria and see if any of those things meet. And I'll give you an example, by the way, kind of a simplified example, because I know there are tables and tables of, oh shoot, I wonder if I have this example. I feel like not all of my pictures downloaded to my phone here for you, so maybe I can't share this. So I know there's tables, the 80 different tests and measures, right? If you are a person with FND and you're kind of like, I never had this testing, do I have it? Those tests and measures pick up on the key diagnostic principles in FND of variability in symptoms, right? So are your symptoms variable? Are they distractible? And I would say this distractibility goes under the variability piece, really. The main question that we're getting at is part of the underlying pathophysiology in FND, is that things can change with attention. Because that's one of the brain circuits that's gone awry in FND. So that variability and distractibility is really testing this. It's testing that change in brain network. It's not testing whether you're faking it. It's not testing that it's psychological. It's testing the influence of attention. And so you can really ask yourself, do my symptoms change with attention, right? And do they have a lot of variability? Do I have periods where things completely go away? If I have tremor, is it entrainable at all? So you could test that out yourself. I'm not advocating a self-diagnosis, but if you've been diagnosed and you're questioning it, or you've been diagnosed and you're like, I don't think I have any of these positive signs, then I think you should go see a neurologist. Now, I'm a huge advocate. If you have a movement disorder, if you have tremor, if you have dystonia, if you have myoclonus or jerky movements or incoordination or ataxia, you should see a movement disorder specialist. That is the person that can rule in or rule out or rule up or rule down movement disorders, and that is their specialty. If you have functional seizures and you had never had a video EEG, it's not required. Again, there's very strong clinical testing, but you might see a neurologist who specializes in epilepsy, right? And you might try to do a video EEG, and that could be helpful for you. Now, I want to ensure folks, you do not actually have to have testing to rule it in. There is testing now. So EMG, EEG are two of the physiologic tests that can be done. But similar to Parkinson's and many other diagnoses, the test can be made on the clinical exam. But I hear from people far and wide that they didn't feel really confident in their clinical exam with a neurologist. And that might mean that you need another neurologist. You need to go elsewhere so that you can feel really confident in that clinical exam. The other thing I would say is do a screen with your physical therapist. They don't give a diagnosis, but they can absolutely do all these clinical tests and signs, confirm your diagnosis, or say, hey, this doesn't really match, and refer you out. They're not going to give you another diagnosis because that's not our job, but screening and referring, 100% is our job. Okay. I see a couple questions come here. I heard of the fear of giving the FND diagnosis and having the patient immediately regress and not willing to accept the diagnosis and skip the opportunity to participate in PT. Have you seen this? Oh, good question. I don't know that I've seen this. I have seen that clinicians tiptoe around it because it has this strong history of being only a mental health disorder, only psychology. What I have seen gone wrong is maybe the other end is they give the diagnosis of FND and then just say, and it's all psychological, go see a psychologist. That is really detrimental for folks who are having a lot of symptoms that are not entirely psychological. Now, I see a psychologist every single week. I love it. I recommend it for every single person that is a human, but especially for neurologic disorders. I'm not saying don't see psychology. I think what I see more commonly is get the diagnosis and then referred only to psychology or psychiatry. I wish that more people were being referred to physical therapy. When the diagnosis, in fact, there's this great article, this is Aunt Bex. By the way, my sister is Rebecca and she goes by Bex sometimes, and she's the auntie to my kids. So I'm just saying, hello, Aunt Bex. That's a really sweet name. So anyway, when the diagnosis of FND is given in this way that we've talked about, a positive diagnosis with an explanation of what is happening in those positive signs, what that means about what's going on with the brain, it's actually a very positive experience for people. People go on to accept treatment for it because it's been explained correctly. So I think when done well, it's actually a very positive experience. But I would love to learn more if there are neurologists that maybe are fearful about giving the diagnosis. Karen is asking, an article you shared a while back, it stated that people with focal dystonia could be FND even though you might not present with distractibility. Great. I'm going to have to remember that article, but yes, there's a couple of really great articles comparing and contrasting focal idiopathic dystonia and functional dystonia. And I would say almost across the board, I see a lot of folks that have both. But also, by the way, not every FND presentation is distractible. It doesn't mean a person doesn't have FND, but that's only one part of the criteria, right? So that's not the only piece of the pie. And then, are you saying EMG proves organic dystonia instead of FND? No. So the EMG findings in the literature are actually for tremor. They're not for dystonia. So EMG does not necessarily distinguish one type of dystonia from another. And EMG, when it comes to dystonia, is really just telling us that a muscle is active. It's not telling us why. In tremor, so the test that I was talking about for tremor, what it actually shows is some of the variability in the tremor frequency that we can see with EMG. Kirsten Jackson, I came and did a month of physical therapy with you at React, and I have not improved. And I want to say thank you for sharing that and for showing up. And I'm really curious why. And I want to follow up on that for sure. I hope you did more than physical therapy. It's very rare that we recommend just physical therapy for a person with FND. Because of that brain network issue, it really is helpful to have a whole team approach. PT, OT, psychology, speech therapy if that's needed. And I would say we have had some people that haven't improved. Some people really blow me away and like are running at the end of 4 weeks, and that's not what I expected. And some people are not. And it means like maybe we missed something, right? So I just want to thank you for that comment, and I would love to follow up on that too. Okay, at some point, would you be able to touch on FND's ability to cause GI issues, motility disorders, and can gastroparesis be a form of FND? Ooh, this is an interesting question. This is not a big part of my expertise, but I will say in the literature, we can see this. And I would say what we see more commonly at Reactive is when people have GI issues, it might be related to their FND, but it might also be related to a comorbid condition. So a hypermobility spectrum disorder, or EDS, or POTS, or some sort of dysautonomia that might coexist with a person with FND. And so what I would say, the GI system, because it's so intricately connected with our brain and our autonomic nervous system, it's often a multifactorial issue. And when I hear GI symptoms too, it makes me want to screen those autonomic factors. Yeah, really great question here too. What if your head tremor or neck spasm gets worse with typing or using hands. So there might be a component there that is task specific. So there might be something about using your hands in the task that might make that head tremor worse. That is not a particular specific sign. That's not a test for FND. It does show that there's some variability there, but there's some biomechanical reasons why using your hands might impact your neck, right? Because of your shoulder muscles. So this is where you should be working with PT to kind of look at why that might occur. Is it a biomechanical issue? Is it a component of a functional neurologic disorder? Do you have a different movement disorder? I obviously I don't know your history, but that alone wouldn't make me say, oh, it's FND, but I might want to look at other things associated. Someone's asking how long to cure FND. Oh my gosh, wouldn't I be the richest person in the world to know that? Number one, there's not research on this. There is no cure for FND. FND is a brain network dysfunction. Now we know the brain networks can change. They can respond neuroplastically to rehabilitation. We know it responds really well to a multidisciplinary rehabilitation. And there's a lot that can be done. Some people have full remission of symptoms and they might not come back. For some people that can seem to happen very quickly in a short amount of time. And for other people, it takes a lot longer. And those are things that we are still really trying to understand. I wish I had a better answer for that, but it's very person specific. And I think that, there is going to be a lot more that we know and understand. And Kirsten said, I did the whole program and I flew from Australia. Well, Kirsten, am I saying that right? Kirsten Jackson, I think. Let's touch base. I would really love to hear about your experience. And can FND be genetic? Ooh. So this is so interesting and such a good question. I was preparing for our Brain Bites discussion on differential diagnosis, and I was reading some new papers on genetic dystonia. And one of those papers started off in the intro and it said, in the 1970s, dystonia was considered a mental health disorder. And I knew like that vaguely, but not that specifically, to be honest. And I've been obsessed with dystonia for longer than I've been obsessed with FND. I'm not gonna lie about that. I find it a very fascinating disorder. And it was upon finding some of the genetic components of dystonia that they discovered, oh, actually, dystonia is a network disorder too. It's a very specific basal ganglia network disorder that's influenced by specific genes. So I say that because I wonder if we're going to find some of that for FND. Maybe they're going to discover some genetic factors that contribute to this brain network dysfunction. At this point, as far as I know, because I'm not a geneticist and I'm not doing this research, so maybe there is somebody doing this and they haven't published it yet. We don't have a genetic basis for FND. There are some cases that seem to run in families, however. So I think there might be more to come there. What is the best guidance for patients with functional disorders who feel pain? I think this is what you were asking, but almost 100% of my patients with FND are experiencing pain. It's a very common comorbid condition. And sometimes that is related to other conditions like hypermobility. that I'd want to screen and see for the presence of, and help support and treat those underlying conditions. And sometimes it's related to the sensory system, their overall nervous system regulation. And I really like to zoom out and really take a whole person approach to look at all of those components together. Why are they experiencing pain? And here's the good news. A lot of what is helpful for many humans with neurologic disorders is helpful for pain. And so we can treat those things together. Another question, do you know what positive signs would be that GI issues is functional? This would be speaking outside of my expertise for sure. There is a whole area of gastroenterology that focuses on functional GI issues. And that is not my expertise. I'm not gonna lie. If somebody was having GI issues, I'm referring them to a gastroenterologist that specializes in that. I have a really great one in Los Angeles, I will say. She's phenomenal. Positive signs for functional dystonia instead of cervical dystonia. Great question. And I have a really great post that I did of signs and symptoms side by side. I'll put it on our stories today. But you can also, like on all of our YouTube videos and all of that, we have a dystonia playlist, and I have several on looking at them side by side. But one of the biggest pieces is looking at the onset of the dystonia. So functional dystonia typically has a more rapid onset to a maximum severity. Idiopathic cervical dystonia typically has a slower onset where it's gradually getting worse. Cervical dystonia often will respond to a toxin like Botox. Functional dystonia sometimes will also respond to that, but in a little different timing and pattern for that. So there's been studies on that. Functional cervical dystonia would have variability in the patterns of muscle contractions. Cervical dystonia, when it's idiopathic, is very regular. So maybe it's that the head is turning to the right and tilting to the left. Very repeatable pattern with very specific muscles every single time. So those are some of the key distinctions. And maybe you can hear in that those are hitting on the big pieces associated with FND in general, which is a variability. Somebody else said, apply for your program, couldn't get selected. Oh, I'm sorry you couldn't get selected. And yeah, we do have specific criteria for our programs at re+active. It's also one of the reasons we created our online membership for people with FND. Coming out to California, doing a whole program here is not feasible for everybody, and maybe not the best fit for everybody too. And so our membership has been a really nice option for folks and a low cost option for folks to learn about their brain and body and learn a lot of the tools that we use. And plus our whole team is in that membership. So I'm going to recommend that one to you. Yeah, I'm asking because both my mother and grandma had some symptoms too. So you're asking about the genetics. So yes, we might wonder if there's a genetic factor. There's a huge environmental factor that would occur from grandma to mom to child, right? And I would just wonder, like, yeah, what's happening in all of our all the brains in our families, right? Like, what are those? I keep coming back to this because this was this great picture from the article that I shared. But do a lot of folks in the family particularly have some of these brain connection dysfunctions that might cause FND? And could that be genetic? I'm so curious. I don't know yet. And yes, there are cases of family FND, but they haven't found like a particular gene for it. Oh, in India, nobody knows about FND. Is there a specific test we can do? So as I described in, gosh, we're going on an hour here. There are loads of clinical tests. So I'm going to share this article. I'm going to recommend this article for everybody. It's called Diagnosis and Management of Functional Neurologic Disorder. Selma Ibach, David Perez. It's from 2022 in the British Medical Journal. Has these, here's one of the tables and tables of diagnostic tests, positive clinical signs for FND that I highly recommend. So what I would say is potentially even bringing this article to a neurologist or a general physician in India to really start that education process. Yeah, really, really great question. And this is why I'm sharing all of the time about this, because there's a lot of misinformation, and in a lot of parts of the world, and you know, in different states too, there's just not a lot of understanding. Yeah. I will share this article in our newsletter this week. I think this would be a great article to bring to a neurologist. There's a couple more questions here before I sign up. So with functional dystonia, your muscles can get big and very tight too. Yeah, they could. If you're really overusing a particular muscle, whether that's in functional dystonia or idiopathic dystonia, it can get really hypertrophied or big, and it can get tight. Yeah, and it might even get a contracture, right? We might have to do some stretching or serial casting or things like that to help a person with functional dystonia. Those things are not, well, I would say not different between a dystonia or a functional dystonia. Now, having tightness and having a hypertrophied muscle doesn't distinguish the two. It could happen in both. So that's not a distinguishing factor. It could happen in both. And in both, rehabilitation would be really helpful. So I need a sip of water. I've been talking way too much, but this is something I'm super passionate about. FND is not a wastebasket diagnosis. It has clear clinical criteria and loads of positive clinical signs. And I understand also that maybe not everybody has had a really positive diagnostic experience. They might need another diagnostic experience and an explanation of those positive signs, or they might have something else, or they might have more than one thing. We see that a lot, and I think it's really important to acknowledge that we as physical therapists especially should be screening people when they come to see us to ensure that, one, they actually have FND, and two, that if they have coexisting conditions or other conditions that might be contributing. So be on the lookout for our newsletter this week with tons of these resources, the research, the videos, and I just want to thank you so much for being here, for being curious with me, and for wanting to dive in and learn, and for sitting in some of the unknown that we still don't know. So thank you so very much, and I will see you again soon.